Hello everyone, I'm Dr. Masha Livhits. I'm an endocrine surgeon here at UCLA.
I'm Michael Yeh. We're partners taking care of this problem.
And we're very excited to be here to talk to you today about a very important topic, which is hyperparathyroidism and its impact on bone health. So I just want to remind you that you can ask questions using the Twitter hashtag UCLAMDChat. And when we're done with the presentation, we'll be happy to answer all of your questions. So what we'll be talking about during this webinar will be first, what are the parathyroid glands and what is their purpose? And then what is hyperparathyroidism? How common is the disease? And who are the patients that are at risk? Why does this disease matter? How do we diagnose hyperparathyroidism and how do we work it up? And of course, we'll get to the treatment and the surgical options. And at the end, we'll have time for questions. So let's start with the beginning, which is what are the parathyroid glands? And what is their function? The parathyroid glands are small hormone-producing glands. They're located in the neck, close to the thyroid. So this butterfly here is your thyroid, and these little yellow circles here, they represent the 4 parathyroid glands. They produce a hormone called parathyroid hormone, and this has a very important purpose, which is to control your blood calcium level. A disorder of the parathyroid glands causes this disease that we're talking about, which is hyperparathyroidism. So to go over the anatomy a little bit more closely, we're talking about this region here in your neck. If you look at this picture here, this again is the thyroid gland. This is your airway, your windpipe, called the trachea. And then if you look a little closer up, next to the thyroid, are these parathyroid glands. And they're called para because they're close to the thyroid. There's a very important relationship between calcium and parathyroid hormone. The purpose of parathyroid hormone, or PTH, is to increase your absorption of calcium. And it does this by acting on both the kidneys and the bone. So importantly, it takes calcium out of the bone and into your bloodstream. It also has an effect on vitamin D. It converts vitamin D into its active form. And vitamin D then increases the absorption of calcium from the intestines and the bone as well. So release of parathyroid hormone is controlled by serum calcium. This is a very important concept because they normally act in opposite ways. So a high calcium level inhibits parathyroid hormone release from the parathyroid glands. So if you had a high calcium for some other reason, let's say you ingested a lot of milk and yogurt products on a certain day, a normal response would be for your body to decrease the parathyroid hormone release from the parathyroid glands. Conversely, if your calcium is very low on a given day because you didn't have enough dairy products or because of renal failure or other reasons, then your body would increase parathyroid hormone release from the parathyroid glands. So when one is low, the other one should be up. So then this gets us to the next important point. What is hyperparathyroidism? Primary hyperparathyroidism, which is the most common form that most patients will have, is when the parathyroid glands make too much hormone. They produce too much PTH, and this in turn increases the serum calcium. There's a certain biochemical criteria which has been described, which is calcium above a certain range, 10.5, and a PTH level above 65. But non-classical forms are increasingly recognized, so a lot of patients will not meet this specific criteria and will still have hyperparathyroidism. So then how many glands are usually involved in hyperparathyroidism? You have 4 parathyroid glands, as you can see here, these yellow circles. And most patients will just have a single gland involved. This is called a single parathyroid adenoma. About 90% of patients will have this. The remaining 10% will have multi-gland disease. And usually that's when all 4 glands are a little bit large, called hyperplasia, and all 4 are producing just a little bit too much hormone. However, there are all kinds of variations. So some patients will have what's called a double adenoma, or 2 enlarged parathyroid glands. Classically, both of the superior glands will often be enlarged in that case, called a double superior adenoma. So a question that we get pretty commonly in clinic is, could it be cancer? Almost always, a parathyroid adenoma is benign. It's not cancerous. Parathyroid cancer or carcinoma occurs in less than 1% of cases. Usually in those cases, the serum calcium is very high, greater than 14 or so, and it could be such a large parathyroid gland that it's even palpable. You feel a neck mass. So in almost all cases, you don't have to worry about this parathyroid gland being cancerous. So the first take-home point here of the talk is that hyperparathyroidism is a disorder of the parathyroid glands causing too much hormone production, which increases your calcium level. So how common is this disease, and who are the patients who tend to get it? It is much more common in women. So approximately 1 out of 400 women will have hyperparathyroidism compared to 1 out of 1,200 men. It becomes more common as we get older. And so the classic patient will be a postmenopausal woman. The average age of diagnosis is 50 to 55 years. And the recognition of this disorder has increased over the past decade. And this is a combination of increased detection through blood tests as well as possibly other sources. So the next take-home point is that hyperparathyroidism is most common in postmenopausal women. Up to 3% of women that are postmenopausal will have it. So the next question is, why should you care about this disease? Now, most cases are discovered on a routine blood test. So greater than 80% of cases are discovered because you go to your primary care office, you get a routine blood test, and this shows a high calcium. This is in Western countries where we get a lot of preventative care. Usually in that case, the calcium is just mildly elevated within about 1 point of the upper limit of normal. So if that's the case, and most patients don't have any symptoms, then why would we care about this disorder? The first reason is that when you actually talk to a lot of patients with hyperparathyroidism, some will be asymptomatic, but a lot of them will have these sort of other vague symptoms that are listed here on the slide. So a lot of them will have joint and muscle pain, fatigue or feeling really tired, some weakness, trouble eating, constipation, poor appetite, frequent urination, having to get up at night to go to the bathroom, trouble concentrating, or what a lot of patients will refer to as brain fog, and mild depression. Now, the trouble is that these neuropsychiatric symptoms are often very vague, and it's hard to always attribute, is it due to hyperparathyroidism, or could it be due to some other condition, such as intrinsic depression? Now, why do physicians care about hyperparathyroidism? We definitely care about your quality of life. A lot of patients with this disorder are truly suffering. There are also a couple of other reasons that we care. One is the impact on the kidneys. So this disorder can cause kidney stones and a slow decline in the renal function. And the other main reason is that it can cause osteoporosis. And in particular, postmenopausal women are already at risk for osteoporosis. So let's talk about the kidneys first. How does hyperparathyroidism affect the kidneys? It causes an increase in your blood calcium level, which causes then increased excretion of the calcium through your kidneys into your urine. And a lot of kidney stones are made out of calcium. So up to 15 to 20% of patients with hyperparathyroidism will have kidney stones. In addition, even besides kidney stones, if you have hyperparathyroidism for a long time and it's severe, you can get a progressive mild decline in your renal function itself, which would show up in the blood test. Up to 15% of patients will have it, and really the patients that are at risk that have this for a long time with severe disease. The next very important point is osteoporosis. So we know that patients with hyperparathyroidism have decreased bone density compared to their peers who are the same gender and the same age. And up to 40% of patients will have osteoporosis as diagnosed by a DEXA scan, which is how you measure bone mineral density. And very importantly, this can increase your risk of fracture, up to a 1.5-fold relative risk compared to patients that don't have this. So this is just typical patients without hyperparathyroidism, and you see your bone mass here in relationship to your age. So your bone mass will peak approximately 20 to 40 years of age, and you can see what happens here at menopause is that bone loss occurs in postmenopausal women. So if you couple this with hyperparathyroidism, these women are really at risk for osteoporosis. So the next take-home point is that hyperparathyroidism increases the risk of kidney stones and osteoporosis. So then, how do we diagnose this disorder and how do we work it up? So very simply, the diagnosis should start with laboratory tests. It should not start with imaging or any other tests. It should really start with the laboratory test first. If you have an elevated calcium and your parathyroid hormone level is also elevated, then almost always you have hyperparathyroidism. Now, patients who have a high calcium but who don't have hyperparathyroidism will typically have a very low PTH level. Not normal, but very low. And if that's the case, then we would consider an alternative diagnosis. So what if the diagnosis is not clear-cut? What other investigation can we do? So a lot of times the calcium or PTH may be borderline, and patients may have non-classic hyperparathyroidism. In this case, we can check something called an ionized calcium. So usually calcium is bound by a protein called albumin in your bloodstream. We can check a free or ionized calcium. That can give us some more information. We can also check a 24-hour urine calcium. Some physicians like to just routinely get this. Our practice is to get this selectively. It can help to confirm the diagnosis in borderline cases. It can also help you to define the risk of renal complications. So if you have a very high amount of calcium in your urine, you're probably at a higher risk for developing kidney stones. Now let's talk briefly about primary versus secondary hyperparathyroidism. Primary, which is what most patients will have, is when you have an inappropriate release of PTH from the parathyroid glands. Secondary is when the PTH is elevated, but it's appropriately so. It's responding to something, which would be an inadequate calcium intake, low vitamin D, renal failure, something that lowers your calcium, lowers your vitamin D, and your PTH is trying to appropriately respond. Now, what if the calcium is high and PTH is normal or low? So we do get some patients that have this where the diagnosis can become a little bit more tricky. And what's often brought up in this case is something called FHH, or familial hypocalciuric hypercalcemia. This is a very rare genetic disorder. It occurs in about 1 out of 80,000 patients. It's due to a calcium sensing receptor in the parathyroid glands and the kidneys, and it changes the set points. So this curve here, you can see in normal patients, the relationship between PTH release and calcium. So in this disorder, PTH is released at a higher level of calcium. Most patients will have chronic mild hypercalcemia, even dating back to childhood. So if you had a blood test for some reason as a child, often you'll have a mildly elevated calcium at that time. They'll typically have a very, very low urine calcium, less than 100 milligrams per day. This can be confirmed with a genetic test, although the genetic test is not always positive. Sometimes it doesn't show up. But the important point here is that surgery is not necessary in this condition. It's not curative. And in this disorder, the bones are not affected because the PTH is not really elevated. So there's really no reason, no indication for surgery in this disorder, although a few patients will have both FHH and hyperparathyroidism that we have to sort out. Now let's talk about malignancy. I said that parathyroid cancer is very rare. There are some other cancers that can cause high calcium, in which case the PTH level would be normal or low. The calcium is usually very high again with other cancers. Usually these patients are pretty sick. They're often hospitalized. And sort of the classic ones that cause this would be breast and lung cancer with metastasis to the bone or multiple myeloma. You can check a parathyroid hormone-related protein that will often be elevated in these cases. And let's talk about just overall other causes of high calcium. So of course, hyperparathyroidism, the most common. We talked about this rare genetic condition called FHH. Hyperthyroidism, if you have sort of a thyroid storm or very high thyroid function at a certain time, that can cause elevated levels of calcium. We talked about cancers. Medications, that's important to remember. There are certain water pills or diuretics that can increase your calcium level, lithium, or even really excessive Tums or vitamin D. So always the first thing to think about if your calcium is elevated on your blood test, review your medication list, and then some other unusual disorders. So this is a pie graph of all causes of high calcium. And if you look, almost all of them are related to hyperparathyroidism in some way. So it's only the purple part that would be other causes. And everything else is some form of hyperparathyroidism. So the next take-home point is that hyperparathyroidism accounts for 90% of high calcium cases. Now, once the diagnosis is secured, that's when we get to the imaging. Imaging studies help us to plan an operation. They should not be used to help make the diagnosis. So let's review the most common imaging studies. The first here is an ultrasound. So you can see the thyroid here, and this black or hypoechoic circle here, that's the abnormal parathyroid gland right here, close to your carotid artery here. Now, normal parathyroid glands are not seen on the ultrasound. They're too small. So if you see a large parathyroid gland on ultrasound, then you know that it is abnormal. The other nice thing about getting the ultrasound is that it'll show us thyroid nodules. And now the next study is a sestamibi. This is a classic study looking for hyperparathyroidism. And what you see here, this is the neck, and you see this black area. So we're looking for a focus of asymmetry on the scan, and we'll do an initial scan an hour and a half later, and see if this focus will persist. And so this would be an abnormal parathyroid gland. And again, you wouldn't see normal parathyroid glands here. You would just see the abnormal ones. And this is very nice because it helps us to make sure that there's no abnormal parathyroid glands in the chest, for example. Now, probably the most sort of modern technology looking at the parathyroid glands is this 4D parathyroid CT scan. It's only available in some places, and we do have it at UCLA. And it really has wonderful definition. It shows us all of the anatomy. It has very high accuracy. So I'll go over this scan here. You can see your carotid artery here, and you can see this parathyroid gland that's flattened right against the carotid artery. And then there's another one on a different patient here where there's a parathyroid gland down here, and this is actually pretty much in the chest. So this is really helpful because for cases that might be difficult, it tells us exactly where to go, gives us this roadmap, and it's particularly helpful in reoperative cases where there's more scar tissue and we're not at liberty to do an exploration the way we normally do. So the next take-home points. Imaging is used to help plan the surgery, not secure the diagnosis. So a negative imaging study does not mean that you don't have hyperparathyroidism. It just means that we haven't found it on our scans so far. Okay, so let's say you've been diagnosed with hyperparathyroidism. Now what? What's the next step? So let's briefly review all the treatment options. The first would be observation. So there are some patients who are not appropriate surgical candidates due to other medical conditions, for example. So observation is a possibility. The problem is that those patients will have a decline in bone density and have a higher risk of fractures. So if you are somebody who's just not a surgical candidate, it is important to stay hydrated, avoid exacerbating medications that we discussed, such as the thiazide diuretics and the lithium, and look at your diet to make sure you're not ingesting an inappropriately high amount of calcium. The next thing to consider is medications. We're always interested in non-surgical options because who wants to have surgery if you can avoid it? The problem is that there are no real effective medications for this disorder. So there are two classes of medications that are considered. The first is something called bisphosphonates. So these are medications that are given for normal patients with osteoporosis that don't necessarily have hyperparathyroidism. And the problem is that there's really not evidence that they are effective in hyperparathyroidism. We have really some evidence that they just don't work in this disease. So the next one is something called Sensipar. Sensipar will decrease your calcium level, but it won't affect your parathyroid hormone level. So what that means is it actually does not have an effect on bone density. So it may lower your calcium and provide some reassurance on your laboratory tests, but your bone density will be actually the same. You'll still have the same risk of fracture. And there's really no evidence of its impact on kidney stones, and so we would hypothesize that it probably does not decrease your risk of kidney stones. So then the next treatment option is surgery, which is really the only cure and a definitive cure for this condition. And surgery does improve the bone density and it decreases your risk of kidney stones, which I'll show you in a moment. So are you a candidate for surgery if you have hyperparathyroidism? There's a certain criteria by the National Institute of Health that sort of gives us some guidelines that if you are in this group, then you're certainly a candidate for surgery. So this includes a very high calcium level, above 1 point, the upper limit of normal, then we'll get to your bones. So if you have a bone mineral density of minus 2.5, meaning you are in the osteoporosis range, then you should have surgery. Or if you have vertebral fractures by imaging. The next would be looking at your kidney stones. So if you've had kidney stones, then you would be a candidate. If you have a slow decline in your renal function, or if your 24-hour urine calcium is high. Now that comes in and out of the guidelines, but that kind of talks about your risk of kidney stones. So if that's high and there's some evidence of kidney stones on imaging, then you would be a candidate. And then also young age, less than 50 years of age, because then you have your whole life to live and you're really at risk for osteoporosis. So these are guidelines. Having said that, there are patients who are even outside of these guidelines who we may consider for parathyroidectomy if they're appropriate surgical candidates. And a lot of it is really the impact on your bone health. So why have surgery for this disorder? And again, it really goes back to your bone health. So this was a 10-year study of patients who were prospectively followed with hyperparathyroidism. Half of them had surgery, and that was based on the criteria that I just showed, and half of them were observed. So the patients who had surgery had an improvement in their bone density, and those are these solid bars that you can see here. And they had no recurrent kidney stones. So none of the patients who had kidney stones had another one after surgery. Of the patients who were observed, they had no change in their bone density. So that's the stripe bar here. So it didn't get worse, but it also did not get better. So it stayed low. And 75% of them had another kidney stone. So the next take-home point then is that parathyroidectomy is the only cure for hyperparathyroidism. And it's the only way to restore your bone density. So let's talk a little bit about the technical details of a parathyroidectomy, which is a surgery to treat this disorder. So this surgery usually takes us about 30 minutes. We do it under general anesthesia, and it's usually outpatient depending on where you live and your social support. It's a pretty fast recovery, and most thing that most patients feel is a little bit of a sore throat. And you can see basically the size of the incision compared to a penny. It's a little over an inch in size. This is how we can confirm that we've cured you. So after we remove the abnormal parathyroid glands, we will measure the parathyroid hormone level during surgery, and it will drop very rapidly. So you can see here, this was a patient who had a preoperative value close to 200. Here we removed the parathyroid gland, and the level dropped to below 50. And this is the normal cutoff in our lab. And then we check it again at 30 minutes after surgery. So we can, in real time, confirm that we've cured you by ensuring that the parathyroid hormone level will drop during surgery. Now, we also will inspect the other parathyroid glands, called a 4-gland parathyroid exploration. That's surgeon dependent. We do that. And in experienced hands, the success rate is greater than 95% for parathyroidectomy for a durable permanent cure. There are some small risks of surgery that are important to consider, the main one being hoarseness. So this structure here is the recurrent laryngeal nerve. It controls the vocal cords. So if this nerve is injured, your voice could become hoarse. And you see the relationship of the parathyroid glands. So the superior one here is behind or posterior and lateral to the nerve, and the inferior one is anterior and medial to the nerve. So it's very important to know the anatomy of this nerve and to protect it during the course of the dissection for the surgery. The other small risks include bleeding, infection, and recurrence, as we mentioned, all about 1%. Now this is an intraoperative picture. A very nice intraoperative picture of the parathyroid gland. So you can see this is the nerve that we were talking about here. And then this is the superior parathyroid gland and the inferior parathyroid gland. The thyroid is sort of pressed away, gently pushed aside. You can see both of these parathyroid glands are enlarged and abnormal. It's very important to know the other potential locations of the parathyroid glands. So classically, the location of the parathyroid glands is what I showed in the previous pictures, a certain relationship to the nerve, to the rest of the neck anatomy. However, every patient is different, and some patients will have parathyroid glands in non-classic locations. So it's very important to know what those are so that if we go in during surgery and it's not where we expect, we know where else we can look. So the next most common sort of location for abnormal parathyroid glands would be deep in the neck, what's called this paraesophageal location. It's down by the esophagus. It's pretty posteriorly or deeply located. And then the other one would be in the thymus, which is sort of in the chest, but usually we're able to access that area through the neck. We just need to know to look there. And then a few patients will have a parathyroid gland that's actually within the thyroid itself. And usually we have a suspicion of that because we'd see a thyroid nodule on the ultrasound. So I just wanted to end by a quick summary. We talked about what hyperparathyroidism means, why we care about it, which are quality of life and the impact on the kidney and the bones, the potential treatments, and really the definitive treatment for it, which would be the surgery. And I really, you can look at our website. It has a lot of great information for patients and other people who are interested in learning more about the disease. So now is your opportunity to ask questions at UCLAMDChat. Maybe I'll let you start.
Yeah. Wonderful summary. It was so clear and so helpful. I hope the audience enjoyed it. So we have a bunch of questions. Wow. Okay. So what is an alternative? Let's just go from the bottom up. The first one is, what is an alternative to surgery for hyperparathyroidism? So observation, doing nothing, or some of the medications, neither of them are great alternatives. If I were to say in a word, why do we do operations for hyperparathyroidism? In a word, it's to prevent postmenopausal women from having fractures later in life. And observation is not going to change that. The bone density will keep on getting worse. Medical treatments also don't change that. These women are still at risk for fracture. So the bad news here is there aren't that many great alternatives to surgery. The good news here is that surgery is fairly simple and safe, and most of our patients you're not under anesthesia for more than 20 minutes, and they go home after just a few hours. So we've done the best we can in terms of making the operation straightforward and simple, and not too much of a hassle for people. You want to try that? Maybe I'll read it. So the usual patient is a postmenopausal woman. In patient groups, we see women just after childbirth. Can we comment on hyperparathyroidism just after childbirth?
Well, I would say that women who are pregnant get a lot of medical care. So that's probably a time when you're getting a lot of blood tests. There may also be some transient time where you're dehydrated, and that could unmask elevated calcium level. Now, having hypercalcemia is very important during pregnancy because there are a lot of effects really on the baby. So if you do discover it during pregnancy, then that's something that we take very seriously and usually have to act on because it can have a lot of impacts on the child that's born. That's
great point. I'm just going to follow up on that. So the question, I guess, perhaps one of the groups, they're finding a spike in women just after childbirth. I agree that maybe that's just the first time many of these women have ever had their blood calcium measured. So we might have just more discovery there. I don't know if that makes sense. And then Dr. Livhits did mention if you find that your blood calcium is high during pregnancy, that's quite concerning. We do see that a couple times a year, hyperparathyroidism in a pregnant woman, which has significant effects on the fetus. So if that's happening to you and you're pregnant, please seek medical attention. We don't, I don't want to scare anybody, but there are higher rates of loss of the fetus. There is a possibility that after the baby comes out, the baby's calcium could fall too low. So this is a concerning condition, and we really advise you to seek medical care if you're pregnant and you have high calcium at the same time. You want to move? So I'll read another one. Can you talk about supernumerary and ectopic parathyroid glands? Are ectopic more likely to become hyperactive?
So supernumerary, pretty unlikely, not impossible.
Meaning more than 4.
Yeah, pretty unlikely to have more than 4, but it certainly can happen. Now, ectopic, we've sort of discussed a range of where normal parathyroid glands could be. It really depends on embryology. So what really is an ectopic or abnormal location of the parathyroid? It really just depends on where they descend. And so we sort of know where that is in terms of where their track is as they descend from during your development. So if they're sort of along that course, it really depends on exactly where they are, but there's probably a range of normal within that course. Now we showed in an earlier slide kind of what the incidence is of the abnormal ones, so you can kind of see how often they are in ectopic locations if they are quote unquote ectopic. Basically my point is that a lot of patients, it won't be exactly where the normal description is, but it'll be somewhere along the course of the normal embryology, so we'll know where to look. And are they more likely to become abnormal or hyperplastic if they're in ectopic location? I don't think there's any evidence of that. Yeah.
I think that so the word ectopic means sort of outside of an expected location. But I think as a surgeon, the way I think about it is, we have to expect the unexpected. We have to know if plan A is not working, where are the other sites, which is why we made that diagram. So, experienced surgeons are going to be able to find most things, even if it's a little out of the way. There's a saying in medicine, when you hear hoofbeats, think horses, not zebras. In other words, common things are common. And I just want to put a little background to this, is that supernumerary glands, more than 4 glands, or ectopic, those things are talked about 100 times more often than they actually exist. And I don't want to sound cynical. in order to prove that somebody's gotten more than 4 parathyroids, we really have to hold ourselves to a high standard. We've got to make sure that we indeed found it, and we took a little biopsy of it, and we looked at it under the microscope, and we found 4. If we found 4 parathyroid glands, and they look okay, and the patient still has bad calcium, then and only then can we posit that there is another gland. And ectopic, really, it's a matter of, it's kind of relative. You know, at what point does a gland actually become ectopic? I think my best advice to you as patients is, you know, these things are often invoked in the case of a failed parathyroid operation. I think we have to talk about this a little bit. So how often is parathyroid surgery unsuccessful? It ranges from 1% to 30%, and that's completely dependent on the experience of the surgeon. Every day we see somebody who's had a failed parathyroid operation somewhere, and sometimes the idea that the patient has an ectopic or extra gland is mentioned. But, you know, when we look at those operative notes, when we look at those records, and when we eventually re-operate on those people, we usually find it's just a normal location. We find it in an expected location. So without sounding too cynical, that's sort of the real world answer to that question. Maybe I'll ask Ashley if we have any more questions trickling in. I'm going to read one more. Is it common to see increases in kidney function after surgery?
Increases meaning normalization of improvement of kidney function. Certainly the kidney function will usually stabilize, and it can certainly improve to some degree also. So yes, it certainly can improve. And this is also the case in something called tertiary hyperparathyroidism, so patients who have had a kidney transplant and continue to have some hyperparathyroidism. If, you know, eventually if those patients require surgery and you treat them, a lot of times that will improve the function of the kidney graft as well. So it can have some improvements.
Sometimes it improves. I think more often it would just stop getting worse. You know, we do have some age-related declines in what we call renal function or kidney filtration function. And when we do operations for hyperparathyroidism, sometimes it gets better. More often it just stops getting worse. And that's sort of our goal. Yeah. We added some more questions. Thanks for all your great questions. These are superb.
Okay, the next question is, a year post-surgery, is joint pain common? I would say probably not if it's related to the hyperparathyroidism. So about 70% of patients get better in some way in terms of their symptoms after the surgery, and about half of those pretty quickly. About half of those takes a little bit more time, maybe a few months. But I would say a year out, probably everything that we can attribute due to the hyperparathyroidism will probably have improved. And so that's when we sort of think about what else could be going on, assuming that you're still cured.
Yeah, I agree. So, you know, one thing we struggle with as physicians is when patients come in and they have many complaints. They're feeling tired, their bones ache, and it's very hard to sort out whether or not it's because of the hyperparathyroidism or because of something else. You know, people can have joint pains for any number of reasons. The good news is that many people after parathyroid surgery feel better in these domains. However, there are some things that don't get better, and we just have to attribute that to something other than the hyperparathyroidism. I mean, everybody's got a right to have fatigue sometimes, you know. So that part's hard.
So next question is calcium and vitamin D. Are they necessary and for how long? That's a great question.
Really
so yes, you do need calcium right after your surgery. As your calcium is dropping down to a normal range, a lot of patients will have symptoms. Some numbness, some tingling, depending on where your PTH is, and it might take a little bit of time for the rest of the parathyroid glands to really kick in. A few patients could have calcium in the dangerously low range, so we give all of our patients calcium supplementation and some vitamin D after surgery. Now the minimum is about 2 weeks after surgery. After that time, it really depends on what your bone health was like before surgery. So if you had, let's say you're a male who had completely normal bone density, but maybe had some kidney stones, then after a few weeks, you could probably stop your calcium. We just wean it off. Now, if you're a postmenopausal woman who had osteoporosis before surgery, then we have recommended prolonging the calcium supplementation indefinitely, or at least for a couple of years, to help your bones maximally restore. Having said that, there's some sort of newer studies questioning how, you know, what the impact really of calcium supplementation is. So I don't know that it's been studied in this particular situation.
Yeah. So yeah, really important question. So sometimes I tell patients that, you know, particularly by the time we meet people, their calcium, if they have hyperparathyroidism, their calcium's been high for a couple of years. And so after surgery, usually about 48 hours after surgery, their calcium will descend into the normal range if we, you know, assuming that the patient's been cured. Now, the body, this is going to sound strange, but grows kind of addicted or accustomed to the abnormal calcium level. And then a healthy calcium level could feel strange. It could feel like a muscle cramping down here in the calves, numbness and tingling. And so we put all our patients on calcium to sort of ease them through that transition. And depending on the bone status, depending on where the calcium started, if you started with a calcium of 13, that patient's probably going to have symptoms of these adjustment symptoms for longer, maybe 6, 7 weeks. Somebody who's just mildly hypercalcemic might have it for a shorter amount of time. So we often will wean people slowly off calcium. Now, Dr. Livhits made the important point of, remember, why are we doing this operation anyway? To prevent fractures in older women. That's the main reason. So we encourage our patients to get enough calcium. Probably 800 milligrams a day is likely the sweet spot for that. We don't want to over-supplement calcium, just the right amount. Get enough vitamin D, which you can get through taking a tablet, getting sun, eating wild-caught fish. These are all great ways to get, vitamin D. These are great ways to get vitamin D, And then the last is to exercise and to submit your bones to some stress. Because when you stress bones through weight-bearing, force-bearing exercise, the bones strengthen. And the classic example of this is baseball pitchers. Baseball pitchers have usually double the bone density in their pitching arm as their non-pitching arm, and we want our patients to have strong bones like that. All right, so maybe I'll go back to, I think we're starting to wrap up. Sort of how long calcium and vitamin D necessary. Vitamin D usually for at least a month. Some of the hyperparathyroidism does cause depletion of your normal vitamin D stores, and it takes a while. Oh, that's a great one. How long will it take for bones to return to normal?
That's a good question.
Great one.
So in the first year, you should see a lot of improvement. So the bone density scan, a year following, that would be when you would see some improvement. But it can take a couple of years to continue to see slow improvements.
Yeah. So bone remodeling is a relatively slow process. Sometimes insurance companies won't pay for bone density measurement more than once every other year. So often we see improvement in 1 year, improvement at 2 years, and then probably the best results are between 2 and 5 years. And then a little bit of bad news, then we all start getting a little older, and as we get older, our bone density might decline a little bit. So can't fight aging. However, the good news is because of that gain in bone mineral density, the overall lifetime risk of fracture falls because the bones got better during that time. You have this durable improvement. And I think that's probably the most exciting thing about some of the work we've done about results of parathyroid surgery. So I think there's one more. Oh yeah, there's a new question. Can muscle spasms be related to hyperparathyroidism?
Yeah, so muscle aches, bone aches can be common in hyperparathyroidism. After parathyroidectomy, if your calcium is falling down or a little bit in the low side, then we see some muscle cramping in the calves. I'd say that would be the main relationship. Otherwise, just a lot of muscle spasms, not that common in hyperparathyroidism.
Yeah, so if I understand the question correctly is, if you have muscle spasms, could that be a symptom of hyperparathyroidism? Usually not. So I would say, look for other reasons and go see your primary care doctor for any additional advice. Okay, and we've got a couple more coming in. Thanks for your active participation. This is really cool.
Yeah.
So why might someone's calcium levels remain high or high normal after surgery if all offending parathyroid glands have been removed? Ooh, that's a hard one.
Yeah, so I would say it depends on what the calcium and parathyroid hormone level are. The relationship. So the first thing is to go back and consider, was the diagnosis correct in the first place? Could it be FHH or something else? So again, go back to how you came to the diagnosis. Now, if the calcium and PTH level are both still remain elevated, probably weren't cured, and then were all 4 parathyroid glands removed, unlikely, then your calcium would be very low. So you have to look at the actual pathology, not just what did the surgeon think they took out, but what were the cells, what did they look like, and really do a re-investigation to see, where is probably the unremoved abnormal parathyroid.
Yeah, great. This question has a lot of depth and complexity to it. Ideally, within a few hours after surgery, the parathyroid hormone level, if it's successful, should fall within minutes. If the patient is cured, if I'm going to read the question, if all offending parathyroids or abnormal parathyroids have been removed, then you should have an immediate parathyroid hormone drop. calcium then should come to normal, usually within 48 hours. If the calcium is high or high normal, again, I'm going to echo Dr. Livhits' comments. We want to look at the relationship between calcium and PTH. If it shows that still the parathyroid hormone level is higher than it ought to be, given that calcium level, it's probably not a great result. Probably means there's something else in there that's not working quite right. And in select cases, we might reoperate on a patient like that. Very challenging question, very challenging case. And there's another, two more challenging questions, and I think that we'll wrap up if that's all right. So the next one I'll shoot at you is parathyroidism has been suggested as a diagnosis. What do you suggest to do after all three? So this person had 3 operations. After all 3 surgeries, level went down temporarily. Wow.
That's a very, very challenging situation. So parathyroidism, very rare. What often would happen is that an abnormal parathyroid gland or adenoma, the capsule was violated during surgery, some parathyroid tissue spilled out sort of into the space and then kind of grew in the neck. Very challenging case. So typically, if the patient continued to have high calcium and have symptoms that would warrant a reoperation, then as this person had, I think, 3 operations, we would go back and try to remove all of that parathyroid tissue. And with each subsequent operation, there's more scar tissue, the risks increase. Sometimes we have to even remove part of the thyroid to really clear out that area. That's really the only sort of possible chance. But otherwise, it can be a very difficult situation.
I agree. Very challenging situation. I'm just going to repeat the question. So the question is about a rare condition called parathyroidism. And this is usually, it arises because of a technical problem with how the first operation was carried out. Now, all these parathyroid glands, the parathyroid adenomas, have a very thin envelope, almost like a layer of cellophane around them, and you don't want to break into that. If you break into that during surgery, the cells can spill out, and then they grow like little seeds in the area. And then I've looked at it under the microscope, and it looks like a shotgun pellets, like little bits of parathyroid tissue showered all over the patient's healthy tissue. And yes, once a year we'll see somebody who usually had parathyroid surgery somewhere else. Technically, there was a problem with the operation. The capsule was violated. They come back. The disease grows back. And then oftentimes we will try to re-excise the area and take a rim of healthy tissue. Obviously, there are going to be more risks with that type of bigger operation. Sometimes we've had a few patients where that did it. More often than not, it will keep on growing like crabgrass. And this person has had 3 operations. That's a difficult situation. You operate enough times and somebody's like, you're eventually going to get a complication. That's when we might invoke a medical treatment like Sensipar to lower the blood calcium with the knowledge that they're far from satisfactory. So I'm going to just give you one last question and then we'll have you wrap it up. So the last question is, can someone with FHH have any symptoms at all? So this was that condition, familial hypocalciuric hypercalcemia, also sometimes known as benign FHH, benign familial hypocalciuric hypercalcemia.
That's a great question. So classically in the literature, it's supposed to be pretty much asymptomatic. So patients are not really supposed to have symptoms with FHH. And part of that is that the calcium usually is just mildly elevated. The PTH level is pretty normal. So I would say most patients, and certainly in medical literature, don't really have symptoms. Having said that, every patient is an individual. There are probably a few patients that have both FHH and hyperparathyroidism, as I discussed. So you certainly have to make sure that there's no component of both. But it's probably not impossible to have symptoms from FHH. It would just be pretty unusual.
Yeah, the reason we call it benign is most of the people essentially are fine. The blood test is, the blood calcium is a little high, but they more or less lead normal lives. They have normal life expectancy and normal quality of life. And that's in most cases.
So thank you so much for joining us, for all of your excellent questions. Please, again, look at our website for any additional information. Thank you very much.
We hope you found this useful, and we'll be back in a couple weeks with another one. And thank you so much for your participation.